I'm Dr. Charan Lanjewar, Professor of Cardiology working at KEM Hospital, Mumbai. Welcome to the CSI Chennai. This is the first day of CSI here, and a lot of crowd is there. Scientific sessions are going very well. My talk was on acute heart failure in hospital management. So, as far as acute heart failure is concerned, since last 2 decades, it has taken big importance in the cardiology. Otherwise, it was a neglected topic in the past. Mortality in acute heart failure since so many decades remains the same or increasing with the incidences. As since last 2 decades, that is 2010 and 2020, there are 2 important trials which have changed the management of acute heart failure in a majority. Like as far as ARNi is concerned, by Paradigm HF trial, which shows the mortality benefit, none of the trial before has shown such a maximum benefit. So since then, there is a change in the acute heart failure management. Then recently SGLT2 inhibitors came in 2020 and become the second line of drug or a 4 cornerstone therapy, what we know as a treatment in acute heart failure. So whenever the acute heart failure comes in a hospital, what are the main therapies you should consider is, one is stabilize the patient, see the hemodynamics of that patient. Diuretics still remains the cornerstone of the therapy for decongestion and stabilization. Second phase in hospital is depending on the hemodynamics, whether the patient will require any circulatory support, inotropic support or a respiratory support depending on the presentation. If not, then once with the diuretic therapy settles down, you can add other pillars of acute failure therapy like ACE inhibitor or ARNi. Second is beta blocker. Third is SGLT inhibitors and the aldosterone blockers. SGLT2 inhibitors, as in number of trials, then recently Impulse trial has come, which showed a decrease in the mortality as well as morbidity in those patients, about 15 to 20% patients in the group of empagliflozins. Again, lot of trials are undergoing. The main concern is when to start these 4 pillars. Consensus is right now, as soon as the patient gets stabilized in the hospital, you can start as quickly as possible, such that till the duration of 4 weeks to 6 weeks you can achieve the full titration maximized dose of these agents. Don't get confused with starting late, because maximum benefit whatever with these drugs is after the onset within 1 month. You can see that major mortality benefit is in that period. If you are missing out, if you are starting after 4 to 6 weeks, the benefits are not that great. So as early as possible has to be started whenever the patient becomes stabilized hemodynamically. To start with, yes, beta blocker. Again, one more important thing, what the precipitating factors which cause more adversity in this hospital is, one is the kidney failure. Most of these patients also have a renal failure, cardiorenal syndrome, what we know as. 1/5 of the patient can have those symptoms. Another problem is cognitive impairment in those patients. This is also a parameter for the more mortalities in those acute heart failure and rehospitalization what occurs in those patients. So these are important things as far as precipitating factors are concerned. Once you start this therapy, you can monitor the urine output and urine sodium levels. A spot sodium can be done after about 2 weeks. See how is the sodium. If it is more than 50 to 70, the patient is well responding to the diuretic therapy. If it is not, you can increase the doses or add another thiazide like diuretic or acetazolamide in those patients. Managing the renal failure with acute renal failure and acute heart failure is really difficult. Here the cardiologists become anxious and stops the ARNi or SGLT2 inhibitors. So there is recently a consensus document by ESC in this year in April, where they have really narrated the issue very well, and the guideline by this consensus is, if the eGFR is more than 20, SGLT2 inhibitor can be started, not to worry about the creatinine storage until and unless it is more than 50% what the baseline of the creatinine. If the eGFR is more than 30, you can start the ARNi. So this is the clear cut guideline now, clear cut consensus on this, so there is no confusion remaining. So in a bottom line, to conclude, acute heart failure still remains a very dangerous cardiac disorder to manage because of high mortality. If you start this guideline directed medical therapy ASAP, outcome is very good. Third is, the patient who are still symptomatic, they are going to come after they are going to get rehospitalized. In those patients, device therapy can also be considered, like CRT, mechanical circulatory support, or ultimately cardiac transplant if he is not responding. So thank you very much and all the best. Enjoy the CSI. Thank you.